Neurocriticon 2009. So we go on to the topic that is the recent updates in neurocritical care trials. There'll be a lot of overlap with the previous as well as the succeeding talks, but I'll go ahead with whatever best. So now we are going on to a field of precision medicine. That means that all the therapies have to be targeted based on the individual, accounting for the individual variability in genes, environment, as well as lifestyle. And the usual one size fits all principle may not be applicable in the field of precision medicine. So whenever we go on to evidence-based medicine and all the lot of trials, we have to be sure that we have to read between the lines because the patient population in all these trials is very heterogeneous. And as a result, most trials have yielded neutral or equivocal results. One example will be the Stitch trial, which was discussed. Actually, if you go into the methodology, you'll find that there was a subgroup in which a subset of patients actually benefited. There's a subset which actually got harmed. So if you identify the correct subset which is likely to benefit, you're going to have a positive study. So one of the major advantages now is that we have an organized neurocritical care network in the form of multiple people from disciplines, places, and improved protocols also, which have led to better outcomes. One of the other trials which has been a benchmark for precision medicine is as we just discussed, the DAWN and the Diffuse 3 trials, in which they have extended the stroke window, the time to intervention to around 16 to 24 hours, the use of better patient selection, the use of perfusion imaging, and subsequently the imaging window was extended. And we have to also remember that all the guidelines are actually not based on very strong evidence. So with this, we go on to the brain injury concept. I won't spend much time on the slide. You have a primary injury, you have a secondary injury. There's primary injury, secondary injury, and because of primary injury, you have the raised ICP leading to ischemia and then the further cascade of inflammatory and excitotoxicity mediated damage. So the overview of this presentation will be, we'll have what are the recent updates in the assessment of comatose patient, what is multimodality neuromonitoring, the state-of-art neuromonitoring, what is the principles, newer principles in management of raised ICP, the recent trials, what do they say, what is targeted temperature management, what could be the optimal hemodynamic management for different diseases in the neuro ICU, what are the recent updates on the reperfusion strategies as well as hematoma evacuation, and a little bit of seizures, non-convulsive status epilepticus. So what is the advantage of having a multimodality monitoring? The main advantage is that your therapeutic strategies before the onset, meaning you can target your strategies in such a way that before you have devastating complications, you'll have better outcomes. You can treat them. So going on to assessment of a comatose patient, we all know about GCS motor score, the brainstem reflexes, the pupillary asymmetry. What is new is there's the study group from Mayo which published this full outline of responsive score or the 4 score, which is actually useful. As we all know, the GCS doesn't have, meaning the verbal score is not much important in intubated patients. Similarly, you don't have much importance in the brainstem reflexes and the respiratory functions. Then you have advanced neuroimaging, which includes, apart from diffusion, perfusion, has also gone on to involve fractional anisotropy with DTIs. And we have both invasive and non-invasive multimodality neuromonitoring. We have also use of transcranial Doppler, continuous EEG, and infrared pupillometry. So this is the 4 score in which, in addition to the eye response and the motor response, you have the brainstem responses, the pupillary and corneal responses, as well as the pattern of breathing. So this can be very helpful in deciding, like in even identifying vegetative patient, comatose patients, when to intubate patients. It's all very useful. So the other novel invention will be your infrared automated pupillometry. It will be more objective. It can be helped in serial monitoring of patients, and just by looking at the velocity of constriction, you can actually identify, meaning you can have serial trends and identify which group of patients is likely to herniate and have more raised ICP also. And obviously, it can also be used for titration of sedatives in your ICU. And there have been studies on automated infrared pupillometry, which have shown that, meaning the values at day 1, especially in patients with post-cardiac arrest state, you can have like a negative prognostic value. That's a higher positive predictive value on specificity for poor prognosis compared to your standard pupillary light reaction. Continuous EEG is another topic which is going to be discussed in the afternoon, so I'm not touching upon it much, but it is helpful in the concepts of refractory status epilepticus, non-convulsive status epilepticus, burst suppression and coma prognostication, like we discussed about subarachnoid hemorrhage and delayed vasospasm. Evolving asymmetry in continuous EEG can give useful insights into the prognosis of patients, sedation depth, as well as in assessment of encephalopathy. What is new in continuous EEG is that now you have more of quantitative EEG techniques. Your routine continuous EEG techniques actually needs a good trained neurophysiologist. However, here with quantitative EEG and spectral analysis, you have a high integrated agreement between ICU fellows, ICU nurses, and neurophysiologists. So it is something which is going to come into practice very soon. And it is useful in the settings of status epilepticus, traumatic brain injury, subarachnoid hemorrhage, especially when there is vasospasm, as well as in monitoring patients with therapeutic hypothermia. So the EEG patterns which will help in identifying is whenever there's a change in reactivity, a change in alpha delta ratio, or the change in alpha variability, you can identify these EEG changes up to around 3 days before there is any clinical or radiological evidence of delayed cerebral ischemia. That's what literature says. So delirium, you have advanced rating scales like confusion assessment method for ICU, brainstem reflexes assessment, sedation score, there's the BRAS score. So what is new in delirium is that the sedation protocols, like there is some evidence to suggest that daily interruption of sedation is useful, provided you are able to adequately manage pain, anxiety, as well as agitation. There is some evidence for use of low-dose dexmedetomidine night dose infusion to allay anxiety, as well as there is definite literature on advantages of active mobilization as well as music therapy. On artificial light therapy in the ICU, the evidence is again equivocal. So this is a slide which was discussed. The range at which you have adequate autoregulation is a CPP between 50 to 150. And beyond this, sometimes when the autoregulation goes off, you have almost a linear association which is very detrimental to the brain. So this is the ICP waveforms which Dr. Shivakumar had discussed in the morning. So you have the tidal percussion and the dichrotic notch. So whenever you have a P2 more than P1, it automatically means that your brain compliance is severely impaired. And this needs monitoring and treatment for ICP. And this is the waveforms which show the Lundberg waves. That is the Lundberg A waves which last with very high pressures lasting going up to 60 millimeter and which can last till around 20 minutes. It means again that your intracranial compliance is coming down compared to your Lundberg B waves in which which happen at a lower pressure and a lower frequency, just almost around 0.5 to 2 hertz. The Lundberg waves, B waves occur. And ICP monitoring has been standardly recommended mainly in patients with traumatic brain injury with a GCS of less than 8. So going on to raised ICP, what are the recent updates and mainly in the field of traumatic brain injury? As we have discussed previously, ventriculostomy will be useful in patients with hydrocephalus, and intraparenchymal monitors are also being used. Others like epidural are not much used. So there was a BEST trip trial which was organized in Latin America which actually shown that with use of intensive monitoring, ICP monitoring, actually there was no difference in outcomes. But again, it should be taken with a pinch of salt because the facility for neurocritical care and the staffing may not have been adequate in those centers. It has been mainly recommended in patients with traumatic brain injury, a GCS less than 8 and an abnormal HCT. So the advantage of a ventricular ICP monitoring is that you can easily recalibrate in case there is a block. You can let out CSF if there is hydrocephalus. It is actually prone to infections, but it reflects more like a global ICP changes. Whereas your intraparenchymal ICP usually reflects only focal changes, and though it is less prone for infections, and you need not recalibrate as much. And based on the ICP, you will get useful evidence, useful information on the autoregulation and pressure reactivity index also. There is an ongoing Cogitate trial comparing ventricular ICP versus intraparenchymal ICP, a randomized controlled trial, the results of which are awaited. So what are the non-invasive ICP monitors? Like TCD, you have a plus minus 12 millimeter, you have correlation with ICP, tympanic membrane displacement, then of course you have a optic nerve sheath diameter which is being practiced extensively. Again, very important to note that it is serial trends which are likely to be more useful rather than single isolated values. So this is a study looking at optic nerve sheath diameter versus ICP monitoring, and actually the ONST predicted non-invasive ICP will be around 5 into ONST minus 14. This will be the approximate ICP value, and this has been shown to correlate with the risk of increased ICP, the autoregulatory index, as well as the need for invasive monitoring as well as mortality. And you can measure the optic nerve sheath diameter in either the axial or coronal planes. The most accurate measurement will be your highest axial measurement. So you can derive a lot of cerebral autoregulatory indices using your ICP as well as your TCD values like pressure reactivity index, your mean velocity index, your autoregulatory index, and you can collaborate with your newer modalities like NIRS, that is a near infrared spectroscopy, which can also be taken into multimodal neuromonitoring. So management of ICP, this has already been dealt with, first line, second line, and third line. Here, as we had already mentioned, when you are going on to burst up, meaning pharmacological coma, your burst suppression ratio should be 0.8 to 0.9. So just going on to critique, what is the difference between 3% saline and mannitol, which was discussed in the morning. Like some of the advantages of 3% saline is that it can be given as a infusion, and meaning you can go up to 23.4% hypertonic saline. But some of the disadvantages which we face is that it causes volume expansion as well as hypochloremic acidosis. We have also had a patient with severe acidosis in which the brainstem vessels also became absent because of brain ischemia. So that should be carefully monitored. Mannitol, of course, causes rebound cerebral edema, and you should target your osmolality to not go more than 320. However, in patients with peak intracerebral edema, you can schedule a dose of mannitol or hypersonic saline to provide enough time for any further intervention like a decompressive craniectomy. So this was a study which was published in World Neurosurgery 2009, which compared hypertonic saline 20% mannitol and 10% mannitol with 10% glycerin. And this was the mean dose which was required to with the ICP monitor, of course. The mean dose of hypertonic saline which was required to reduce the ICP to less than 15 millimeter mercury was 1.4 ml per kg for hypertonic saline, 2 ml per kg for mannitol. Similarly, the mean time to reduce ICP was much shorter in hypertonic saline compared to mannitol and mannitol glycerin. And this was more useful in traumatic brain injury. The trial was done in traumatic brain injury, and there is also a minor trend towards improvement in outcomes with hypertonic saline, considering its anti-inflammatory and membrane stabilizing actions. The effect of mannitol on supratentorial hemorrhage, intracranial hemorrhage, the evidence even from meta-analysis is very sure that it leads to more hematoma enlargement, it leads to increased mortality, and most of these patients had cerebral edema which worsened. So this was the status of data on mannitol in intracranial hemorrhage, hypertensive hemorrhage. So going on to decompression, again you have to identify whether it's a focal pathology or a global pathology. If it's global pathology like a traumatic brain injury, the data is less convincing. The rescue ICP and the DECRA trial both have not shown very good improvement. Of course, with the rescue ICP trial you had, which was published in NEJM, there's higher odds of survival, but many of the patients actually survived in a vegetative state, which is also not very helpful. So this is again which was discussed, decompressive hemicraniectomy in stroke. The classical trials for the Decimal, Destiny and Hamlet all were European trials, and which included patients who are aged less than 60 years with MC involvement more than 50% and a bad NIHS score. There was definitely a mortality benefit by 50% and an improvement in functional outcomes by 16% if the surgery was ideally performed within 48 hours. And of the survivors, 55% had moderate disability, whereas 18% were independent. Extension of these trials was Destiny 2 trial, in which they included patients who are aged more than 60 years and found out again that there was a mortality benefit and a functional outcome benefit. Then we had a DCAP trial which was published in Neurocritical Care, a recent trial conducted in Germany. The advantage of this trial is that it also included nearly 50% of patients with dominant hemispheric involvement, again a gray area. And here they identified that there's a lesser chance of survival without disability, which is also important, and the case fatality rate at 1 year was nearly 43%. As already discussed in cerebellar strokes, there is overwhelming evidence for suboccipital craniectomy, and that need not be discussed. So this is regarding decompressive craniectomy in cerebral venous thrombosis, a large retrospective study which was conducted in our center, which again showed that these, in contrast to arterial strokes, patients with CVTs actually, though they had a low MRS score at discharge, they tended to improve over the next 1 year, and at follow-up of 6 months, significant proportion of percentage of patients actually had a MRS score of less than or equal to 2. Then going on to targeted temperature management, again the evidence is mainly in hypoxic encephalopathy. So here, what is the importance of targeted temperature management in hypoxic encephalopathy is that we are actually going into an era where we are going to use more and more of ECMO, LV assist devices. The patients post cardiac arrest might need immediate interventions like angioplasty or even CABG in some cases. So as a neurologist or as a neurointensivist, you are called many times to prognosticate. Do we need to go ahead with all this as early as 2 to 4 hours or even 6 hours after the resuscitation from a cardiac arrest? So that's why the management of hypoxic ischemic encephalopathy needs to be very evidence-based. So the standard methods need to be followed, like cooling we'll be talking about, and you should maintain adequate saturation map, glucose levels, etc. So multimodality prognostication is again important, because once you do all this, again you have to prognosticate based on your clinical variables, your comorbidities, your SSEPs, your continuous EEG monitor, like biomarkers like fortunately here at least we have some biomarkers like neuron specific analysis, which can be used at 24 hours, 48 hours, 72 hours. Diffusion weighted imaging after 72 hours can help in lot in prognostication. Fractional anisotropy on a DTI as well as pupillometry can also help in prognostication. So the main principles in management of HIE will be: one is to identify and correct the cause of cardiac arrest and support it with ECMO or LVSS devices or with revascularization strategies. Then, as already discussed, you have to maintain a proper metabolic milieu. You have to restore and maintain it. So that's where the hypothermia comes into place. You have to treat ongoing seizures, which could be in the form of status epilepticus or myoclonic status. And it is especially important to use continuous EEG if there is neuromuscular blockade also being used to prevent secondary brain damage. And eventually you have to prognosticate at 3 to 7 days and assess also, because many of them will have neurocognitive problems later. So this is the risk score which came in AN for the early stratification following a cardiac arrest. So you can characterize them as low risk, medium risk and high risk based on what is the duration of cardiac arrest, that is the no flow interval, what is the duration to return of spontaneous circulation, what is the motor response initially, what are the imaging findings, what is the EEG pattern, that is how much of burst suppression is there, is it, meaning it is less than 10%, is it 10 to 70% or more than 70%, based on which you can give a risk stratification as early as 6 hours after a cardiac arrest. Then regarding HIE associated seizures, how aggressively to treat it? Again, the good prognosis will be if your epileptiform discharges arise from a reactive or a continuous EEG pattern, or you have multifocal discharges from a good background. Whereas if you have like periodic discharges, it warrants aggressive treatment also, and it's a poor prognostic factors. And it is important to realize that many of these patients you'll identify as non-convulsive seizures and put them on long-term sedation, which can again interfere with your prognosis. So as your duration increases, that is 3rd to 4th day post-arrest, you'll have to correlate with biomarkers and your MRI DWI for adequate prognostication, whether to continue treatment or not. Then regarding targeted temperature management, you have many trials which we'll be discussing some of them. So you have therapeutic hypothermia, you have controlled normothermia. The advantages, the postulate is that it will reduce the cerebral metabolic rate, your ICP, as well as prevent blood-brain barrier disruption. It needs to be started as early as possible. There are data regarding pre-hospital arrests also, but the earliest it is initiated, it is better, because for each 5-minute delay or each 30-minute delay, there are trials to show that the outcomes are worse. It needs to be continued at least for 12 to 48 hours, following which rewarming needs to be done at a time for between 0.25 to 0.5 degrees Celsius per hour for 8 to 12 hours. Prognostication ideally needs to be done 72 hours after rewarming. And there is a proportion subset with severe shock again, in which your temperature management needs to be only between 35 to 36 degrees centigrade. So the methods of cooling, again there are various methods including intravascular cooling, water circulating blankets, conventional cooling and air circulating blankets. Each of them has different temperature decline rates as well as a drift from your temperature maintenance. Important to note that intravascular cooling methods have been proven to be much more effective than the conventional cooling methods in terms of your speed of temperature, speed of attaining hypothermia as well as your maintaining hypothermia, thus avoiding drifts. And newer intranasal and surface cooling methods are also available. The disadvantages of therapeutic hypothermia, of course, is that there is an increased bleeding risk and increased risk of infections as well. So this is a meta-analysis of multiple trials in which they looked at out-of-hospital cardiac arrest. So those who had a shockable rhythm, that is a VF or VT at admission, had a better mortality and outcome benefit compared to those who had asystole. That is the learning point from this article in Resuscitation which came out in 2018. Similarly, a Green Journal article which also had a practice guideline, again patients with a shockable rhythm had a better outcome compared to those with asystole or pulseless electrical activity. So other points to note about these hypothermia trials is that the main two trials which proved that hypothermia is better in, meaning is advantageous in a cardiac arrest situation, were the European and Australian trials which are published in 2002-2003. However, in the control arm which didn't receive hypothermia, many patients actually had fever. So that was one thing which tended to see that. Again, there was a trial in 2013 by Nielsen et al. In which they found that 33 versus 36 degree, actually there was no change in mortality or outcomes. So in spite of a lot of data, there are some trials in which the control group was not, meaning the temperature was not controlled properly in the control group, which could have led to a beneficial outcome. And the other question is that, does the hypothermia less than 31 degree also help? That's another question for which a lot of RCTs are on the way. Traumatic brain injury, there is a definite recommendation to maintain normothermia, not for hypothermia, because all the hypothermia trials have shown that there is no improvement in outcomes. And there's a recent POLAR trial again which has shown that no advantage with therapeutic hypothermia in patients with traumatic brain injury. In subarachnoid hemorrhage, there was a case series recently which came out in 2019 with 7 patients only, which showed that actually hypothermia can help in preventing neurological complications after onset of severe vasospasm and raised ICP. So going on to blood pressure management, you have two arms here. The arm in which you have to be careful with maintaining the pressure head, that is those with acute ischemic stroke and vasospasm after subarachnoid hemorrhage. The other group in which you have to manage the BP more aggressively. That includes patients with intracerebral hemorrhage, hyperperfusion injury post endovascular procedures, as well as patients with untackled subarachnoid hemorrhage, untackled aneurysms and subarachnoid hemorrhage. So these are the guidelines which we have already discussed: 195 by 110 before thrombolysis, less than 180 to 105 for at least 24 hours post thrombolysis. The patient is not thrombolysis, 220 by 120 is the guideline, and you have to come to a target of 140 by 90 at a rate of around 10 to 20% per day by 7 days based on the CATIS trial. And the target BP with newer reperfusion or mechanical reperfusion strategies is still not properly defined. So this was the Enchanted trial in which they looked at intensive control, that is meaning patients with acute ischemic stroke who are being thrombolized. They looked at patients with intensive control, that is 130 to 140 in 1 hour versus a guideline, and then improved over 24, the BP control is maintained over 72 hours. Actually, there was no change in functional outcome. However, there was a small difference in incidence of incidence of intracranial hemorrhage, that is 14.8% in the aggressive group versus 18.7% in the non-aggressive group. So this was a guideline regarding after mechanical thrombectomy, what should be the guidelines for blood pressure control. Again, here it's been shown that if you maintain around 180 by 105, again depends on what flow you are achieving, whether you are able to reperfuse completely or partially. If you are reperfusing completely, the risk of hemorrhage is much higher with 180, 105. So you have a moderate blood pressure control as a recommendation. That is less than 160 to 90 was found to be a better predictor of 3-month mortality. So there is risk of hyperperfusion with endarterectomies as well as stenting and embolectomies. And there's a simple trial which was published in 2008 regarding the size of infarct volume reduction after upper limb pre-ischemic preconditioning. The logic was that in the non-paretic limb, if you inflate the BP cuff to suprasystolic levels and maintain for 5 minutes and then relieve for 5 minutes, keep it doing for 15 days, they actually found that there's a 31% reduction in the infarct volume in patients who had this conditioning done. The basis for that is that a lot of humoral factors are released, the autonomic nervous system gets activated, and some inflammatory markers are also there which could have positively managed the infarct volume. The BP control, these trials have already been discussed. I'm not discussing. Interact, Interact 2, Attach, and Attach 2. Attach 2, of course, had a higher risk of renal complications in the intensive BP control group. And this again will be a topic which will be discussed later. That is what all, and has already been shown in a few slides before, that is symptomatic ICH after intervention, what needs to be done in terms of plasma factors. It's important to note that you shouldn't reverse very aggressively also, because all these factors are thrombogenic and can lead to more thrombosis, especially in settings of CVT, etc. So then regarding sedation versus intubation for your endovascular stroke treatment, mainly trials have not shown any difference between the two groups. However, 3-month outcomes have been bettered, meaning 3 months outcomes as measured by MRS have been better in the GA group compared to the sedation group. There are a lot of, at least 3 trials which have shown this data. Then what about when to intubate patients who have a low score? There is a set point and set point 2 trials in which they found that patients who had an early tracheostomy done after a major stroke actually had a lesser sedative use, a lesser ICU stay and mortality. A larger RCT of set point 2 is still awaited. Then regarding thrombotic and endovascular therapies, all this will already be discussed partially. So very again, like with DAWN and diffuse trials, you have actually increased the therapeutic window based on careful selection of patients. Like you have chosen patients with aspects more than 6, like who have a discrepancy between your perfusion and diffusion weighting imaging, and a core less than 70 ml and a penumbra more than 15 ml. And you have to also realize that all these large vessel occlusion data is mainly for anterior circulation strokes. There are very few data on posterior circulation strokes. All these trials have been in anterior circulation strokes. And the wake-up stroke also based on your diffusion flare mismatch, there has been improvement in your MRS at 6 months. Tenecteplase, again, like the incidence of higher large vessel recolonization rate compared to RTPA is higher compared to RTPA. So that's the advantage of having 10-hectare place. So endovascular therapy in CVT should be ideally recommended in patients who have neurological deterioration despite adequate anticoagulation, who have thrombosis of the deep sinuses. Important to know that patients who have large hemispheric infarcts, it's better not to offer endovascular treatment in CVT because they tend to have worsenings immediately. And the plan of management will be mechanical thrombectomy combined with intraoperative thrombolysis, or you can have continuous catheter retained there and continue thrombolytic therapy, which has been proven to be safe. Data from a larger study, THOAC study, is still awaited. Regarding hematoma evacuation stitch, I already mentioned there is a subgroup which benefited with aggressive treatment of hematoma and evacuation. This included patients with 50 to 70 years, a GCS of 9 to 12, and an expanding hematoma of volume of 20 to 50. So these patients might benefit from a open craniotomy. Again, stitch again had two groups, one in which there was definite benefit, one in which there was definite worsening. So when both the groups were missed, actually the whole data got diluted, and there was also significant crossover noted between the surgical and the control groups. That also needs to be noted. So the MISTI group of trials in which your already Dr. Ranjan had mentioned, you keep your catheter there, transfuse RTPA, and then do manual aspiration. Again, the MISTI 1 and all had shown improved outcomes. Then you had finally recently in Lancet 2019, you had the MISTI 3 trial. That is again for patients with large cerebral hemorrhage more than 30 ml. It did not, the trial results actually, the primary outcome which was assessed was what is the proportion who achieved a good functional outcome at the end of 1 year. That primary endpoint was negative, but if you look at the subgroup analysis, you can actually see that the MISTI group in which the minimal intervention was done had a lower ICH volume as well as lower ICP events also during the course of hospitalization. And again, if you look at the MISTI 3, you'll identify that almost they were able to identify a target ICH volume of less than 15, which is the initial recommendation for intracranial hemorrhage management in only nearly 60% of patients. And all the patients in whom they were able to achieve meaning ICH volume less than 15 ml after the procedure actually had good functional outcomes. So again, you have to read between the lines. Again, a pooled data analysis which came the current edition of Green Journal, in which they've shown that all the hematoma evacuation techniques, minimally invasive techniques, might be beneficial. Other ICH trials, I won't deal it with much. Again, like ischemic stroke, there is also role of sonothrombolysis in hematoma management as well as stereotactic aspiration without thrombolysis. Enrich trial, in which they have looked at minimally invasive surgery using a small craniotomy for hematoma evacuation. Again, results are completely, meaning full results are awaited. Then you have the clear IVH trials in which patients with intraventricular hemorrhage, you had catheters, meaning you had the EVD being put and then fibrinolytic therapy with RTPA being given to see what is the functional outcome and what is the hematoma evacuation. Actually, they found that there were lower risk of mortality as well as pooling the MRS and GOS, that is a Glasgow outcome score. The outcomes are also better in the fibrinolytic therapy. So in IVH, this has been definitely indicated the use of intraventricular thrombolysis. Other trials in which they have combined with lumbar drainage have also shown good data. Going on to status epilepticus, we are just concluding fast. So going on to status epilepticus, regarding ketogenic diet in status epilepticus, they have found that patients who are able to achieve a ketosis within 2 days of starting the diet, almost 80% of patients actually had complete resolution of the SRSC at a mean duration of 5 days.
I request Professor Ajith to please.
Yeah, we're winding up. So the newer antiepileptics like brivastam, which is an analog of levetiracetam, which has better CNS penetration, as well as an AMPA receptor antagonist by name perampanel. So there are better status epilepticus scoring scales like ENDIT scale and EMSE scales also. Some advanced modality monitoring like cerebral microdialysis, which Dr. Shivakumar had already discussed, to identify whether your metabolic milieu is adequate or not, looking at the lactate and pyruvate ratio. Then you have brain tissue oxygenation monitors, which can be kept proximal, meaning in close proximity to the site of brain injury to detect the cerebral oxygen flow as well as the oxygen tension. That was the BOOST-2 trial. Then you have regional cerebral flowmetry techniques also, and of course you have your near-infrared spectroscopy techniques also, which can be very non-invasive and help in identifying patients for monitoring your cerebral autoregulation in the CNS. So the conclusion is that definitely you have better biomarkers, you'll have definite endpoints for all these trials, and you might have good conclusions or very valid conclusions. Otherwise, you have to always take a lot of conclusions with a pinch of salt. And there is likely to be a discrepancy between what is seen between the blood pressure, ICP, as well as what is happening at the molecular level, which could be leading to some disturbances in individualized management. So it is always important that you individualize treatment looking at the physiology, the metabolomics, the proteomics, that is the fingerprinting of the metabolites, the proteins in the body, the genome, as well as the connectome, that is the connections between all the nervous system. And of course, the main strength is that if you have a multimodal disciplinary team, which includes a neurologist, a neurosurgeon, an intensivist, a proper nursing staff, your outcomes are likely to be better. Thank you.